Thank you so much. I'm really grateful to be here. In fact, I want to start with a couple of expressions of gratitude. First, you know what happened 75 years ago this week? The Allies invaded Normandy and helped to rescue Europe and probably the world, and I personally wouldn't be here. My family was rescued, so I want to start with that expression of gratitude. And second, gratitude to be here with these fancy people, this faculty. I'm truly honored, and I'm only an adult cardiologist. I was never smart enough to become a pediatric cardiologist. I'm not just joking. So my name's Lederman. I run a lab at NIH. My job is to think of kooky ideas that might be interesting to help physicians solve problems, and then to introduce them into clinical practice. And this slide is a summary that shows some of the work we've done. Today's just going to be an overview. There isn't much time. And I want to just give you a taste of what we do, and I want to try to inspire you. Maybe you'll have a kooky idea that's worth pursuing. And if you have one, I'd love to talk about it, and maybe there's some way my lab can help you. So I also start by talking about my close colleagues who do all our projects together nowadays. Vasilis Palviaros and Adam Greenbaum at Emory. Toby Rogers, who was my fellow at NIH, is now at MedStar Washington Hospital Center. Jaffer Khan, who's a fellow. Kanishka Ratnayaka, he's like you. He's a pediatric cardiologist who was in my lab briefly and is now at Rady Children's Hospital in UCSD. And Chris Bruce, who just started a few months ago and has already invented, I think, the coolest procedure in interventional cardiology. So I'm going to start with transcaval access and closure. You can see I left breadcrumbs along the bottom of my talk, so we'll see what I'm able to get to. Can we go to your big questions? So, do you, answering as if you were not only U.S. citizens, but New Yorkers? Oh, God. All right, well, we'll go back to this slide. We'll interrupt my talk in a minute. So if you can go to your big interactive website, whatever that is.
So we can everyone go to Pull Everywhere. If you don't have it already on your phone, you go to the App Store and go to Pull Everywhere.
Oh, God.
Or you can just log on the web browser.
Okay.
It doesn't work with Google. You're going to have to put it into the web browser bar at the top. So it's just that website at the top, pullev.com/t-course855. Capitals doesn't matter. Let me know if you get it. So once you log on, you're going to have to type in your username and hit continue, and that should directly enter you into the poll questions.
You say that.
So
Go to your web browser. So I already got it.
you got it.
I got it.
You can join the app and you got it.
So is it pollev.com/tcourse855? What does that magic number mean?
I should have introduced that before you started. Sorry, we're going to
It's fine.
this the whole meeting. So what's your web browser? No. Web browser. You can put your name.
Oh, that's awesome. I'll put it here. Everyone put Eric as your name.
So this question is about transcaval access, and that's putting a hole in the abdominal aorta from the adjoining cava in order to get to the other side. And so the first time I discussed this with a Canadian, he didn't know I was involved in the project. What's the name of that guy at Sunnybrook, the TAVR operator?
It's very funny.
What's the guy's name?
I just want to tell you, I was with him yesterday,
Yeah.
and he told me the story.
So he's a really nice, Sam, lovely guy. I was at some conference and I told him about it, and I asked him what he thought of transcaval, and he said, "Oh my God, that is the stupidest thing I've ever heard of." And being Canadian, he was mortified when he learned it was a project I was involved in, but it's a perfectly fair answer. So, do you, answering as if you're not only U.S. citizens but New Yorkers, do you think that transcaval access is stupid? Okay, so we're only down to 25%. My goodness, that's progress, because it used to be 100% of people thought it was stupid. Can we go back to the slideshow and maybe we can see these answers as they accrue? Okay. And also, just by a show of hands, has anybody in the room done a transcaval procedure? Oh, good. I don't know about that. I need to learn. Okay. Did you do it by, So did you do it by on purpose, or did you do it by accident?
I have done patient with stenting
I've done in smaller patients who are even spent.
I see, by transcaval. Oh, that's great. I want to talk to you about it. Okay, so the idea is, if you talk to a surgeon about transcaval access, they think it's ridiculous because every surgeon in their career has seen a patient with an exposed retroperitoneum, and that patient bleeds out because the aorta or cava has a hole in it. But remember that in a closed retroperitoneum, the surrounding interstitial fluid, represented here by soda water, is higher pressure than the vein. So if there is a hole corresponding to the aortic hole in the adjoining vein, instead of having catastrophic aortic bleeding like here, the higher pressure in the interstitium forces the arterial bleeding to decompress spontaneously into the vein. That physiology supports this procedure. So here's a representative transcaval procedure. We burn across an electrified wire into a prepositioned snare. We exchange for a Lunderquist wire. We deliver our TAVI sheath to TAVI, and then we close it with an Amplatzer nitinol occluder. And in a minority of times, you get a complete occlusion like this. More often, there's a residual fistula. Remember I said the interstitial fluid has higher pressure than the vein. So here's an unrepaired aortic cable fistula. The operator pulled through the nitinol occluder. It's fine. The blood pressure gets a little lower because you have a left to right shunt, but it's fine. As a matter of fact, after implanting a nitinol occluder, the fistula was still present. There was 0 retroperitoneal hematoma that day, and there was 0, of course it occluded shortly thereafter. I know the work's controversial, so when we set out to study procedures, we pay close attention to data veracity, and we use 100% independent monitoring to verify the source data against the case report forms. And we have independent adjudicators. In this case, we also did systematic pre-discharge CT. If you did pre-discharge CT after every TAVI procedure, you would find 20-25% major bleeding and major vascular complication because all these patients have a small hematoma either around the puncture site or in the retroperitoneum. In any case, we did a self-funded systematic study in 2015 with 17 mostly inexperienced sites. In fact, half the sites had never even done one before. And the procedure succeeded most of the time, except for one hospital that didn't have electricity. And these were partner cohort C, meaning they were inoperable or worse. These were patients who had no good option for vascular access. There was no subclavian access at the time. And we found that at 30 days, the major life-threatening bleeding rate was about 12%. That drove vascular complications. What's interesting is that in follow-up, these patients died of non-vascular complications. In follow-up, there were no late vascular complications of a nitinol occluder in the aortic position. We were able to prove fistula occlusion in almost all. Only one patient did we have proven fistula patency after a year. And fistula patency didn't predict mortality or heart failure. So I thought that was kind of interesting. But putting these results into context, in comparison, Edwards did a very careful TAVI study of intermediate risk patients, partner 2 study, and put into comparison, our predicted mortality was significantly higher than partner 2, and compared with partner 2 transfemoral, our life-threatening or disabling bleeding was higher, but compared with transthoracic access for TAVI, our major bleeding was significantly lower. Since then, there have been more than 1,000 cases at more than 100 sites. Both Edwards and Medtronic are willing to offer commercial partnership. It's been used for some other applications. That's why I'm showing it to you. I'm very interested to learn more about Dr. Amin's experience. It's been used for Impella and TVAR. It can be used widely, even if you have an abdominal aortic aneurysm, even if you have an abdominal aortic graft. And the main contraindications are a calcific window, absence of a calcium-free window in the aorta that you can traverse, or operator unfamiliarity. There's a very interesting signal that's been presented and not yet published from the TVT registry from the last 3 years. For patients who have non-femoral access from the subclavian or carotid position, surprisingly, these real-world data suggest that the stroke rate is significantly higher than transfemoral. Now, TVT registry hasn't been capturing other, but I'm certain that almost all of the other cases in the TVT registry are indeed transcaval, and surprisingly, our stroke rate is only slightly more than transfemoral, but not to this almost alarming incidence observed subclavian carotid. This, of course, needs to be verified, and this is just registry data. The procedure is a little challenging for adult cardiologists who aren't as slick with Amplatzer devices as you all. And so we worked hard to make a purpose-built closure device. We worked closely with a company named after my lab, Transmural Systems in Boston. And they made a device that, unlike Emplazer devices, which lengthen when you pull them through a tube, this device has a spring that makes it shorten when you tug on it. So it's incredibly easy to use. I'm sorry, it may not be projecting so well. It also has a lot of fabric, and it has a central guide wire port so that you don't have to give that up. And it works better, it's easier to use, and when you color it green, it looks really pretty. In our first Inhuman Study, it worked great, and in 30-day follow-up, it worked great. We just need this company to get some money to introduce this to commercialization. So I'm going to end every segment of my talk with a Grooviness Assessment. I think that transcable is groovy because it's the best and most carefully studied among the non-femoral access techniques. It's extrathoracic, like subclavian axillary carotid. The ergonomics, I haven't discussed this, are really good because you're standing at the groin and not underneath the image intensifier. The stroke rate may be lower. It seems to have acceptable safety even using off-label devices, and it can be taught and learned. And most important, it's really cool. It's not groovy because it costs a little more money, takes a little time to learn, and a handful of patients are not eligible. So it's important that your skill set include other non-femoral access routes. Overall, I think it's groovy. So we'll see at the end of this talk whether I've changed your mind. Okay, let's change on. One last point about transcable. I don't know if you have highlights for children in Canada. I certainly did growing up in the physician's waiting room. Please, if you want to do a new procedure like this, don't be like Goofus. Be like Gallant. Ask for a proctor. You need some help learning a new procedure. Okay, let's change directions to Lampoon. Lampoon means intentional laceration of the mitral leaflet to prevent LV outflow tract obstruction during transcatheter mitral valve replacement. So Vasilis Balbiaros a few years ago approached me and said he's having trouble implanting a sapien valve into the mitral position because it shoves the antemitral leaflet into the LVOT, especially in patients who have small hearts, small enough to accommodate a sapien valve. And even in those who don't have fixed LVOT obstruction, a handful of others will have a long antemitral leaflet extending downwards. And this is subject to dynamic LV outflow tract obstruction, or SAM. The alternatives to this are not doing the procedure and letting the patient go to hospice, or surgical access with leaflet resection, which is a pretty morbid procedure and mortal procedure, or a procedure that's gotten popular but may not be so attractive, and that's transcoronary alcohol septal ablation, because it's complicated by oedema, as you guys spell it, and it's complicated by anatomic miss. You know, God didn't put the septal perforator artery there to prevent LVOT obstruction, and put it there for other reasons, and it doesn't necessarily correspond to the myocardial territory you intend to ablate. Okay, this is an animation so you know what the heck I'm talking about. Retrograde across the aorta, you put two coronary guiding catheters, one at the base of A2. You blast across using transcatheter electrosurgical techniques, and then we position a special thing I'm going to call a flying V. I'll show you that later. And we slice electrically the anteromitral leaflet from base to tip. Then we implant the sapien valve, and look in this groovy animation. Blood can flow across these struts. I want to point out, though, this is not a perfect solution. And in fact, it wasn't until we started our systematic trial that we recognized that in some patients, the skirt of the sapien valve can itself be obstructive. And so the pre-procedure planning is very important. That said, it can work. If you don't know what I mean when I say neo-LVOT, neo-left ventricular outflow tract obstruction, we plan it on CT, we simulate the implantation of a sapien valve, and this is an example of a patient who has essentially zero neo-LVOT. And I mentioned a moment ago the skirt neo-LVOT. This is unfortunately something we only recognize the hard way in some patients who got sick. So this is a TE of our blasting across A2 during a Lampoon procedure. This is some of the animal work done by Jafar Khan showing split of A2. Here's one of the early patients where the sapien valve is extending all the way across to the septum. In this patient, we would have completely excluded the LVOT, and that patient would have woken up dead within a few minutes. But instead, there was, albeit turbulent flow across the sapien stent struts out the LVOT, and an acceptable gradient. So we did a systematic trial after figuring out how to do the procedure. It was 5 centers. Edwards gave us a little money, thank goodness. You needed to be eligible for sapien 3 TMVR, meaning you had a small enough annulus for valve and MAC or valve and ring, and you had to have certain geometric characteristics and no good clinical options. As in our other trials, we used 100% source data verification by independent data monitors as well as independent adjudicators. So what I'm saying isn't a lie, even if you don't trust me. We enrolled 30 patients, and that would be for good reason. We enrolled 30 patients. The traversal and laceration was successful in every one, irrespective of calcium patterns. There was no LVOT obstruction on exit from the cath lab. However, 3 patients needed alcohol septal ablation for bailout because we didn't recognize the problem of skirt neo LVOT, a lesson learned the hard way. Those patients still did okay. There was remarkably no stroke. And our survival is pretty good. 100% 30-day survival valve and ring, 87% survival for valve and MAC. These are patients who are the worst candidates for transcatheter mitral valve replacement because their hearts are so small. There's some other nice applications of Lampoon. It taught us a lot of lessons, and that's why I'm excited to show this kind of procedure to you. Joffer, the fabulous fellow in my lab, flew to Brighton to help David Hildick-Smith with his patient who had a sapien in ring. Eric, you got to see this. This is cool. Come on. Look, there's a long leaflet causing... I'm sorry, too. This patient has dynamic LVOT obstruction, had a gradient of 100 after TMVR in ring. So Joffer flew out and did an incredibly easy 5-minute procedure, put the flying V, I promise I'll show you what that is, electrified this lacerating surface from tip to base, and in just a few minutes reduced the gradient to trivial, and patient was restored to class 1. That was pretty cute. We call that rescue Lampoon. Some patients have an Alfieri ring, Alfieri stitch, which may not be such a great procedure surgically, but seems to have been recapitulated with MitraClip. Patients with Alfieri stitch may be, by virtue of having a double orifice, may be rendered ineligible for transcatheter mitral valve replacement. Using Lampoon-like techniques, it's crazy easy to slice this leaflet and do TMVR if there is some kind of landing zone. And although it's a little hard to discuss it here, one of the transcatheter mitral valve replacements, the Lampoon, the Tendyne device, we have done Lampoon to overcome the problem of LVOT obstruction in a patient who had no options whatsoever, and we made this patient eligible for this investigational device. Maybe more promising, there's a great excitement in the application of MitraClip for both degenerative and functional MR, but what the hidden secret is, especially for functional, MitraClip's just not a great therapy. And these patients often go on to progress, and they may progress to the point of needing some other intervention, but having clips in A2, P2 position can preclude TMVR. In a very simple procedure, we're able to slice the anterior leaflet and then put in a transcatheter mitral valve. The MitraClips get shoved posteriorly. Here we're looking down from the apex of the heart. And we can render a patient eligible for TMVR in a procedure that we call ElastiClip. So stay tuned for more of that. Finally, Vasilis Babiaros and Adam Greenbaum, who've been really leading the show in the clinical application, have made the procedure a lot easier. Instead of going retrograde across the aortic valve, they're able to do a Lampoon procedure now antegrade through 2 transeptal deflectable sheaths and corresponding guides, and this makes the procedure a lot easier. We're going to tinker with this a little more, and then I hope publish it soon so that you can all learn how that works. So Lampoon's really groovy because Vasilis Babiaros came to us with an idea. We did our first animal in May, on May 3rd, and then on May 25th, a few days later, we went to our first patient who was in dire need. So the procedure is cool because it enables TMVR in patients otherwise ineligible, irrespective of calcium. It seems to be successful most of the time, and it's inspired a bunch of new procedures. However, Lampoon is still really stuck because you still have to do a transcatheter mitral valve replacement, and the available aortic valve device used heterotopically, the Sapien 3 device, is not really well suited for valve and ring or valve and MAC applications, and it suffers, for example, from bad paravalvular leak and hemolysis, and it still remains technically groovy. But in spite of that, I think, in my grooviness assessment, Lampoon is kind of groovy. Now, let me change directions to transcatheter electrosurgery in general. I do this with some humility because I think I'm speaking to the inventors of transcatheter electrosurgery, especially Dr. Benson. Him. Thank you. So the idea is to use a unipolar electrode. We put one electrode on the skin. We use our other guide wire device as a unipole. And we're not doing coagulation. We're not doing cautery. This isn't the Civil War with a heated sword thing. Our goal is not to coagulate blood. We're using continuous duty cycle RF to blast away. We truly intend to vaporize tissue. I wonder if there's going to be audio here. Do you have audio on your HDMI? If you don't, it's okay, but it's just the coolest sound. So this is just in some egg white, and this is what's happening. There's an explosion in our patients, and that's what you have to do. If you have a lot of exposed guide wire, nude guide wire, I'm sorry to be so titillating, it's just not going to work because you're just going to be heating the blood around the naked wire. You have to confine the electrode. You have to confine the charge to the tip using tips with insulation on the wire, using catheters, and then you can blast away like this. So that's what we use to traverse transcable. That's what we use to traverse the base of A2. But to slice a leaflet is a little harder because I know you all took an exam on this and you all got an A, but if you just take a guide wire and bend it like this, it's going to heat on the outer curvature of the elbow if this is straddling a leaflet. What we want to do is we want to focus the energy on the inner curve, the inside of the elbow. And so in order to do that, we have to selectively denude just the inner surface, non-circumferentially, and we also have to rely on catheters and insulation to focus that charge in what we call a flying V, because it's just like the rock and roll guitar. There's one final trick, and this is a special sauce to transcatheter electrosurgery if you intend to slice a leaflet or a corresponding structure. I know Eric's called, so you should pay attention to this one. If we just have a wire suspended in blood, this is not going to behave like surgeons. Remember, I'm the junior varsity surgeon. The surgeon suspends their Bovie electrosurgery pencil in air, which is non-insulating. So they're able to cut without the fear that their charge is getting dispersed some other place. But when you're electrifying your device inside the bloodstream, there are lots of alternate current paths, and that's bad. So what we do is we bathe the target in non-ionic fluid. Dextrose in water, D5W, is non-ionic. And by doing so, we're assuring that the only way for current to get from this unipole to the indifferent electrode on the patient's skin is through the leaflet. And that helps you blast away. I'm going to move on because it's getting dark. So with that in mind, I'm going to change to another application. Danny DeVere approached us and said, hey, can you do Lampoon in the aortic valve to prevent coronary obstruction? And I told him, well, actually, it was one of our first thoughts that Jafar Khan, the fellow working on the project, wanted to, and I wouldn't let him. I was afraid of causing stroke. So we started out with a really stinky Basilica procedure. Here's what the acronym stands for. Remember, my lab is mostly an acronym foundry. But then we got all pretty. This grew nice. So remember, the coronary obstruction for TAVI is a catastrophe. Even though it's rare, it's often not survivable. And it happens when the coronaries are low and the root is small and the sinotubular junction is low. So the current strategies, in most of the United States at least, is to deny TAVI. If the patient's eligible for surgery, that's great. If the patient's not eligible for surgery, they usually go to hospice, but some docs do snorkel stenting, which I'm not going to discuss here. That means stenting the left main or right coronary artery out into the aortic root and then crushing that stent with your TAVI device. Doesn't make sense. So our idea is to blast across the base of the leaflet that's threatening a coronary and use the same flying V to slice the leaflet. And after you implant the TAVI device, the original leaflet gets splayed open. So here's an animation, again, to show you what the heck I'm talking about. Guiding catheter in the base of the target leaflet, another catheter holding a snare in the LVOT far away from the mitral valve, blast across the base of the target leaflet, deliver your flying V and electrify it, and now we have a split leaflet. What's interesting here, I forgot to mention this for Lampoon, is that these leaflets coapt. So whereas you might be afraid, or we were certainly afraid, that our patients are going to suffer catastrophic hemodynamic collapse after the Lampoon or the Basilica and before we put in the definitive procedure, that doesn't seem to happen. The partial coaptation seems to be adequate to allow the patient to tolerate the next 20 minutes before you put the device in. And then after TAVI and after Basilica, the threatened coronary is purportedly perfused normally. Here's an example of a patient who on planning CT had a virtual valve to coronary distance of close to 0, and the mechanism of obstruction was deficient sinus. This patient also had sinotubular junction narrowing, So this is a phenomenon we would call sinus sequestration. So this patient had two mechanisms of coronary obstruction. So we position a snare in the LVOT, blast across using transcatheter electrosurgery, snare, and externalize that guide wire. And then this is the part that most operators can't seem to get right. It's the preparation of the flying V. It's crazy easy. You just need to learn how. So we position a hubless microcatheter called a piggyback in the middle of the guide wire. This is while we're already across the leaflet. We selectively denude one surface of the guide wire, no more than about 120 degrees, and then we kink it using the back end of a scalpel. You can see the shiny part on the inner curvature. You all see that? So scratchy, scratchy, kink, hard, boom, flying V. It's nice, right? But it's amazing. The most talented operators in the world, they keep screwing this up. Okay, so with the flying V in place, we give dextrose. I'm sorry that these movies didn't play in sync. We give dextrose, and you pull no harder than lifting a milk carton. If you're pulling harder than that, you're risking avulsing a leaflet, and that creates new problems and doesn't necessarily protect the coronary artery. You have to slice the leaflet, not tear it. And then after TAVI, here's a demonstration of that left leaflet. This coronary artery would almost certainly have been occluded by the long leaflet mitral flow. Dr. Horlick, you okay? But are you okay? Okay. So we studied this systematically, again with an independent source data verification and so on, in patients who were thought to be high-risk coronary obstruction, however that is defined, whether they had sinus effacement or sinus sequestration mechanisms. And 30 patients, 37 leaflets, we failed to traverse in 2 leaflets, and in one snorkel stented, the other just abandoned because it was a borderline case. And the procedure was successful in 28 out of 30. And here's the worrisome thing. There was one definite stroke. Nobody had cerebral protection. There were 2 patients who had possible stroke. I think it's unlikely because they had baseline either brain metastases that were extensive or demyelinating syndrome. But the 3% or even higher stroke rate is indeed worrisome. That said, it seems to work. It's teachable. And we have these new groovy-shaped catheters that Medtronic made for us that we call Pachyderms. You know the thing you do with your kids? Can anybody make the Pachyderm sound? Nice. Thank you. Well done. Okay. So that was fabulous. So the clinical comparison to Basilica is just anecdotal. And the risk of stroke is a little concerning, so we need to study this a little more. That said, it's been done about 250 times, and there were almost no subsequent strokes after the early experience. I didn't describe this, but Basilica, the right coronary, is quite challenging, and a doppio, as opposed to solo Basilica, is a real pain. And you should probably only try this if you're going to start with a left-only solo Basilica. It's also important to point out that TAVI and TAVI is probably not suitable for Basilica. We're investigating this a little bit. Oh, please don't try it. So I think it's only kind of groovy. Again, if you're interested in Basilica, please don't be like, I don't know what happened to my slide. Okay, yeah, well, don't be like Goofus, be like Gallant. Let me change directions to Percutaneous Glen Shunt. This is another application of transcatheter electrosurgery that I hope is useful to you. Kanishka Ratnaik has been running this project for many years, and he applied it so far only in one patient, but I hope it's interesting to you. So he found a patient in San Diego who's young with a single ventricle physiology and limited pulmonary blood flow, but low pulmonary vascular resistance. So the CT shows the proximity of the cava to the right pulmonary artery. He put in an anchor stent in the supravena cava. I'm starting to have slide problems. He did electrosurgical traversal. You know what? Can you hit escape and then shift F5? Because I'm starting to get really sad that the movies don't work. This is only worth showing if this... Just hit escape and then shift F5. Thank you so much. Let's hope it works better. So electrosurgical traversal using standard transcaval technique in 2 projections, and then snared, then externalized, then exchanged for a rigid wire, and then implanted a couple of Cheatham platinum covered stents, as well as an anchor stent in the RPA. And what's nice is that 2.5 years later, she's doing swell with a dramatic functional improvement and adequate oxygenation. So this is really encouraging, I think. And so Kanishka's working really hard with this company, the same company, Transmural Systems, under contract to make a purpose-built endoside and end-to-end anastomosis device to affect a transcatheter Glenn shunt. And it's going to be applied in children. So stay tuned, or talk to us if you want to work with us on this project. We don't quite have enough money. That's actually the way somebody could really help. But the device performs magnificently in animals. And we intend to pursue the humanitarian device exemption pathway. I hope you like that. I think that's really exciting. So I'm running out of time. I want to talk about 2 more things. I could shut up, or I could talk about 2 more things. Okay. So there are 2 more themes. One is transcatheter suture procedure, which is another way to say transcatheter surgery. And then the other thing is my latest, which is Cerclage. It's my latest and also my oldest. So here's some work in progress. We call it PASTA, Pledget-Assisted Suture Tricuspid Annuloplasty. The idea is to recapitulate the Hetzer surgical double orifice tricuspid annuloplasty by putting in 2 pledgeted sutures. This is how it works in animals. We've learned to put pledgets in to really enhance our pull-through force by having double puncture, pledget, recapitulating surgery. We're going to traverse the tissue with transcatheter electrosurgery. We're going to exchange for sutures, and we're going to close with a surgical device called a core knot that's used surgically. You may not be familiar with it. It's a staple-type device that has a delivery system that's just long enough we can reach from a jugular approach. Here's a schematic using a deflectable guiding sheath. We crossed twice at the RV free wall annulus, cognizant of the leaflet base, cognizant of the right coronary artery. We exchange those 2 guide wires for a pledgeted suture. And then, although there is no annulus on the septal side, we substitute a bite through the septum and coronary sinus to get purchase, to put another pledgeted suture pair, and then pull those together and tug them together with a core knot. It looks something like this. So we've done it in a small number of patients. Here's a patient who had just had horrendously dilated functional tricuspid regurg with a dimension more than 7 centimeters. Here's a torrential TR. So we worked on this. It took us many hours, more than 5 hours. And for 5 blessed minutes, we succeeded in creating this double orifice and near abolition of tricuspid regurg. And then the tissue avulsed. And the patient was, quote, fine, had a complete return of his torrential tricuspid regurg. So there's something wrong with the small number of pledgeted sutures that we're applying because we're not able to redistribute force adequately. I still think it's pretty interesting. There's another related procedure that Vasilis Balbieros did to address another horrible problem, which is post-infarction ventricular septal defect. Traditionally, I'm sure there are a lot of people in the room who have tried to put, and successfully put, Amplatzer-type devices through the orifice of a post-infarction VSD, and that's a horrible trajectory. It almost sets up the device to fail. The idea here is to traverse a non-endoluminal trajectory, even through hybrid surgical exposure, if need be, to go straight through the target and make a sandwich using sutures of nitinol devices. And this has been done, and here's a patient who had a nice result in a horribly tortuous post-infarction VSD.
How long after?
2 days. So it didn't matter that the tissue was gelatinous. It didn't matter that it was oedematous, because the oedema, as you say it, I don't even know where I am either. So the oedema is interesting because what happened is a few weeks later, about 5 weeks later, the VSD recurred because the oedema swelled and or the ventricle remodeled a little bit. So they came back and put in another bunch of suture pairs. And this patient really did swell. So these are still works in progress. They're intended to just provoke or stimulate you. I think it's cool because we really are, by exchanging guide wires that have traversed for sutures, we are doing transcatheter surgery. But when a surgeon does a stitch, you watch them work, they're really talented. They do a suture a second, and we do one suture an hour. And that doesn't give you a lot of time to put a lot of good sutures. That's part of why PASTA failed, not enough sutures. So stand by. Can I talk about cerclage and pasta, or you want me to shut up? I'll try to make it quick. I want to give breath, I'm sorry. So there have been some approaches to do transcatheter mitral annuloplasty through the coronary sinus, and a lot of these have failed. A lot of the mitral annuloplasties in the coronary sinus, they want to accomplish this, but they really accomplish this because they're not rotationally aligned in a satisfactory fashion to achieve septal lateral apposition. Also, coronary arteries are frequently entrapped. They're undermining the coronary sinus. And there's also this apical disjunction business where the coronary sinus can often be so far from the annulus that there's no good way to narrow the annulus. And finally, there are some transcatheter solutions that implant a bunch of anchors. Really brilliant engineering like Cardioband. And these anchors, unfortunately, hit bystanders like the circumflex or are subject to single anchor failures that are a recipe for failure. Our solution is to compress extrinsically. And I'll show a little more about this. We want to just encircle the valves in trapta or in cerclage. Trapta, or transatrial intrapericardial tricuspid annuloplasty, we poke a hole out of the right atrial appendage. I'm sure everyone in the room has done this before, just not by on purpose. We do it by on purpose. And then we navigate the pericardium, put a lasso around the base of the heart, tighten it. It works great in animals. It's been stuck in our commercial partners' hands for 4 years. I want to shoot myself. But I hope we'll finally make it into patients next year. Cerclage, on the other hand, I think is really groovy. I've been working on this one since 2007. So cerclage is an attempt to navigate the coronary sinus, poke a hole in the septum using non-electrosurgical techniques to encircle the mitral annulus and LVOT. So watch this video made by our company partners, Transmural. Through a transjugular sheath, we put a basket-like target in the RVOT, making sure we're through the major orifice. Through the same sheath, we engage the coronary sinus, and then go into a vein that runs parallel to the left anterior descending, and those typically have a septal perforator vein that was put there by God to enable cerclage. And using a CTO coronary guide wire, we poke through a short segment of interventricular septum into the waiting snare, externalize both free ends of the guide wire, and you see where we're going with this. Now we're going to exchange this guide wire for a suture-like tension device. We have both free wires outside the neck. Suture-like tendon device that's been crimped onto it, and that suture device also has an incorporated arch-like coronary artery protection device. And that coronary artery protection device allows you to compress the mitral annulus as much as you want without crushing that circumflex. Now we have both free ends of the suture-like device, and we're going to put a wishbone-like lock system in, with one side straddling the tricuspid valve into the RVOT, and another side in the coronary sinus. This allows us to position a lock, and we interactively, under echo guidance, apply tension to compress the annulus and achieve the geometric and functional result we want. When we're satisfied, we cut and release. Okay? So we did in animals, worked well in an animal model a long time ago. My former fellow Jun-Han Kim got frustrated with how slowly I'm making progress, and he made a homemade device using his industry incubator, and in his home city of Busan was kind enough to invite me to do the first human cerclage procedures. And the results were surprisingly good. Here's a representative case where functional mitral regurg was reduced by 2/3 and persisted out to 6 months. So did the regurgent volume, so did the left atrial and ventricular volume, so did the brain natriuretic peptide, and interestingly, atrial fibrillation spontaneously reverted. Here's that same case. Look at the shrinkage of the heart after the cerclage procedure and shrinkage of the atrium and ventricle on CT. It's a small number of patients. In fact, I think the results are too good to be true, but the regurg volume and ERO and chamber volumes all reduced compellingly over 6 months. My partners at Transmural Systems have made an easier to use system. We've actually I flew here from Atlanta where we just implanted in our second patient, and this device, which is very slick and easy to use, seems to be working in our early experience. So I think these are groovy, cerclage and trapta, because we're using extrinsic compression. We're able to overcome problems like coronary compression, coronary entrapment. The clinical results are pretty encouraging, but of course it's still very early, so please stand by. So overall, we've been able to make some procedures that I think have been interesting. I hope they are provocative to you. But what's nice is, I guess that you pediatric discovered this long ago. We're no longer confined to individual vascular chambers. We can traverse any wall we want. We can traverse and connect any chamber we want, not just close holes. And transcatheter electrosurgery is just part of our trip towards transcatheter surgery. So please learn to burn. Thank you.